So adolescents are a special breed, and one of the important points to remember as you approach questions on the exam that have to do with adolescence is that the boards do not want you to treat them like little adults, and they don't want you to treat them like big kids. So they need their own kind of treatment because they are big kids and they are little adults. And so you need to temper your mixture with both of those. So this is a guide to where we're going to go for the next 2 hours. We're going to start off with wrapping up orthopedics that we started with yesterday. There are a couple of concepts that we're going to raise that are specific to adolescence. So first, a couple definitions. I don't know about you, but I always mix up sprain and strain. So it's helpful just to see it in print. A sprain is a stretching or tearing of a ligament or a joint capsule, where a strain is a stretching or a partial tear of a muscle, and a rupture is a complete tear of a muscle or tendon. Back pain is a great example of how to approach problems in adolescence because this is where you can't approach it like you would an adult. So even though some of the problems that occur in adults also occur in adolescence, the adolescents require a special approach. So let's separate it out into acute and chronic. Under acute, you have lumbar disc disease, muscle strain, which by far and away, this one is going to be your most likely diagnosis in most cases. It's also true in adults, but it's important to realize that there are other things that happen in kids. Sciatica, others that are much less common, and then chronic back pain, lumbar disc disease as well, spondylolysis and spondylolisthesis, both of which we'll discuss, scoliosis, and then others that are less common. So let's start with scoliosis. Scoliosis is the lateral curve of the spine of greater than 10%. 10% of the curves progress and require some medical intervention. We'll talk about how and when those tend to progress. And there's no clear underlying cause that we know of. So one of your jobs is to screen for scoliosis. And probably the easiest way to do it is what's called the Adams forward bend test, where you simply ask the patient, where you sit behind the patient or stand behind the patient, get down at the level of the hips of the patient, ask the patient to bend forward, equally trying to touch their toes with their fingers, equally trying to touch right and left, and you look for asymmetry. Positive test will be showing a rib hump or a bump, and this is a hallmark of curves that are greater than 10%, which are ones in which you need to probably intervene or at least provide more aggressive screening. So this is obviously a case where you don't even need to do the test because you can see the patient has scoliosis when she's standing upright, but you can see when she does the Adams forward bend test that she has a significant hump, and she obviously has significant scoliosis. When you're screening patients, it's not going to be this obvious, and you need to be more careful and look at how the creases in the back are folding out and whether or not there's a rib hump. So how do we classify scoliosis? It's based on the age of the child when it's first diagnosed, so we put it in 3 categories: infantile, juvenile, and adolescent. And if you look at the infantile scoliosis, it's very, very uncommon, so we don't even really screen for that. Juvenile scoliosis is detected between 3 and 10 years and just accounts for up to about 20% of disease. So the vast majority of the disease is occurring in the adolescence, and it's believed that that has something to do with the growth spurt and the preparation for the growth spurt that these problems start to arise. Girls are more likely to progress than boys, so that's just something you should know as you're screening, because if you find a girl with a small degree of scoliosis, you need to watch her a little more carefully than you would the boy. A lot of it has to do with the future growth potential of the patient, and we talked yesterday about different ways that you can measure that. One is through looking at growth curves and what percentile they're marking at and what you expect. But the greater the growth potential is measured usually by their Tanner stage, which we'll talk about a little later, the more likely their scoliosis is to progress. So you also need to carefully measure the curve magnitude at the time of diagnosis. The larger the curve, the greater the likelihood of progression. And we'll also talk about how you can go ahead and use x-rays if you need to measure that curve. So when do you screen? The American Academy of Orthopedic Surgeons and the American Academy of Pediatrics differ a little bit in their guidelines, but I would suggest that you look at setting targets at least for every other year, but probably every year is better. But you can see the guidelines are fairly similar. Each allow a year off. So girls between 11 and 13, and boys at 13 and 14. That's just to provide for the difference in when boys and girls tend to reach the height of their pubertal development. So that's what you're really looking for, is when they've started, when they've actually finished their growth spurt. Some red flags: any severe pain that's associated with the scoliosis is definitely a flag. If there's a left thoracic curve, noting 90% of the curves are to the right, so the left tend to be more significant and cause more problems. If you do a neurologic exam of the lower extremities and you notice any deficits, that of course is a red flag. And then significant stiffness. So if the patient, if it significantly limits their mobility, it can be a serious problem. To make the diagnosis apart from your screening, so remember we talked yesterday about the difference between screening and diagnosis. So screening is a procedure that's applied to a mass asymptomatic population. And the purposes of screening is to seek out the need for further intervention or further diagnostic studies. So if you do your screening through whatever method you choose, the Adams forward bend test or some other, if your screening is positive, then you move into a diagnostic modality. So when you're trying to make a diagnosis, what you're most interested in is the measurement of the curve. And there are standards in radiology for how to measure this. So if you do just a posterior or anterior x-ray of the patient in the standing position and ask your radiologist to measure the scoliotic curve, then they have a standard way that they go about doing that. You can use an MRI. As I mentioned, the left thoracic curve is highly unusual, and so that tends to be involved with other problems. So you might need an MRI in that case, or if there's a high degree of pain or any abnormalities on your neurologic exam. The treatment generally is bracing, and this is long-term bracing. You obviously are not going to do this on your own. You're going to involve your orthopedic surgeon and your orthotic specialist to develop these treatments for you. But it generally is pretty good at preventing significant progression, but it does not correct, it's not going to correct the underlying problem. So in some cases, in extreme cases, you may need to resort to orthopedic surgery. All right, a little warm-up question for you this morning. We have a 15-year-old gymnast here who presents with acute low back pain that's worse with extreme extension. What is the most likely diagnosis? So 15-year-old gymnast with pain, back pain that's worse with extreme extension. Is it A, muscle strain, B, spinal stenosis, C, osteosarcoma, D, spondylolysis, or E, spondylolisthesis? Grab your button box and make a choice. All right, so could it be a muscle strain? Certainly could be, but remember, I warned you against choosing the adult-like answer. So hyperextension, you have to remember what hyperextension is, right? That's this. So, you know, for those of you who are watching the Olympics, there's a lot of that going on, right? And I'm going to discriminate for you the difference between the two spondylos, because I always have a hard time remembering which is which, but we're going to go over each of them. So thankfully not too many people picked B and C. That's good. You know, that would be an unusual presentation of osteosarcoma, and spinal stenosis tends to present more with lower extremity complaints. A patient like this is clearly at risk for a muscle strain, but you need to think about spondylolysis, which is a fracture. And this is due to hyperextension. It is an overuse injury in adolescent athletes, especially gymnasts, weightlifters, and football players. There are others as well, most common 10 to 15 years old. And one of the easy ways to test for it is just do this standing straight leg raise. And what that forces the patient to do, if you have them stand holding a rail or the wall and you have them hold their leg out, it forces you to compensate by hyperextending your back to balance yourself so you don't fall over. And what that does is provoke the pain. So this is a stress fracture of the pars. Usually affects the 5th lumbar vertebrae. The easiest thing to do is to start with a plain x-ray. But if you're still suspicious, if the straight leg is positive and you're dealing with a kid who's at risk, again, somebody who's doing regular hyperextension of the spine, you should consider an MRI. It's often misdiagnosed as a muscle strain, so it's important to try that straight leg raise to help differentiate that. So the treatment is no back extension, physical therapy, sometimes a back brace. Rarely you need to resort to surgery. Spondylolisthesis, on the other hand, occurs when one vertebral body slips forward in relation to the one below. So it's a simple movement, usually between L5 and S1. And here's a schematic of that, so you can see the vertebrae slips on top of the other. And this can cause spasms that stiffen the back, some tightening of the hamstrings, changes in posture, and it will start to narrow the spinal cord if it progresses or gets more severe. The symptoms are back pain, usually that radiates posterior to the knee or even below the knees, and it tends to be worse on standing. So oftentimes these patients will complain that they get spasms in their hamstrings. Again, a lateral x-ray with the LS spine attention is going to hopefully get you the diagnosis. You'll see that slipping. And the treatment, again, is generally conservative, so it's teaching the patients how to stand in a different way, how to stretch those muscles out so you reduce that level of stress at that point in the spine, and strengthening the muscles of the abdomen and the paraspinal muscles. So these are things that are generally related to activity, and they can be exacerbated with growth spurts, so the things to watch out for. Limited activities, surgery is very uncommon, but they can do a spinal fusion if the problem becomes significant enough that you're starting to develop significant deficits. And then orthotics are always helpful. All right, another orthopedic question for you. An obese adolescent boy with no history of trauma has a dull ache in his hip. Pain is increased by physical activity and relieved with rest. Internal rotation and flexion of the hip is decreased. Which of the following is the most likely diagnosis? So is this A, spondylolisthesis, B, leg calf Perthes disease, C, slipped capital femoral epiphysis, D, developmental dysplasia of the hip, or E, Osgood Schlatters disease? So go ahead and grab your button box and make a choice. Okay, so this was a textbook example. I gave you all the clues, and you got them. So we're going to talk a little bit about SCFE. So characterized by displacement of the epiphysis from the femoral neck. You can actually see it on X-ray. It's one of the more common hip disorders that you'll see. It's also one of the more serious. So it can lead to significant disability if it's not appropriately treated. 15% will present with isolated thigh or knee pain. So a good rule of thumb in orthopedics or in sports medicine or rheumatology, any joint area, when you've got a patient who's got a complaint in a joint, you always need to make sure you look at the joint up and the joint down. So if somebody's complaining of pain around the knee, it's really important to examine the hip and the ankle. A lot of times cases present as referred pain. So it's always important to examine the adjacent joints. Pain with SCFE is increased by physical activity and generally relieved with rest. Mean age 12 years in girls, 13 and a half in boys. Again, probably speaks to that difference in development. Bilateral in about 20% of cases. And in unilateral disease, the contralateral hip then slips later in up to 60% of cases. So even the kid who you treat and get through this, you need to watch the other hip. Diagnosis with an AP lateral hip X-ray. You see posterior displacement to the femoral epiphysis, and it's described as the ice cream slipping off the cone. And I'll show you a little diagram of that. So you can see on the right-hand side there that here you can see the slip where it's starting to move downward. It looks like the ice cream here is falling off the cone. Treatment, this requires a referral to an orthopedic surgeon. As I mentioned, without appropriate treatment, this can lead to serious disability. Patients need to be admitted if their hip is at all unstable. They may need surgery right away. It depends on the degree of the hip slip. Bed rest may be needed for those who have bilateral SCFE, but again, the goal of treatment is to prevent further slippage. Osgood Schlatters disease is also another common orthopedic problem. It's also an overuse syndrome. It's very common in athletes who use their quadriceps a lot. So you see a lot of soccer players, basketball players, football players, where there's a lot of jumping, squatting, and running, that kind of thing. So that places stress on the tibial tuberosity, and with repeated contraction of the quadriceps, you actually get a point of inflammation there. So it usually occurs in adolescents and pre-adolescents who've undergone a growth spurt. So again, notice a lot of these problems that we're going over right now are typical of adolescents who are going through their growth spurts. But this is a nice representation of where the issue is. You can see with that constant contraction here of the quads up here that you're putting stress down at this point here, which is the attachment at the tibial tuberosity. So you often will see some swelling, some inflammation, and it can cause some avulsion of the ossification center at that point. Patients complain that they have anterior knee pain. Sometimes they'll actually complain of pain right over the tuberosity. So the typical scenario is the patient will tell you, I've got pain right here, right below the patella at the tuberosity. And they can tell you that it's made worse when they go through activities, especially those that involve contraction of the quadriceps. It's relieved with rest. And the best thing to do is use NSAIDs and ice. A lot of times ice before can help, but certainly ice afterwards. Again, they'll complain of that localized tenderness. You may actually see or feel a little bit of warmth or swelling there. And the pain can be reproduced when you ask them to extend their knee against resistance. So all you have to do is have them at the edge of the table, and you hold their leg in, and you ask them to try to resist your hold, and they'll complain of the pain. You can also do it by squatting, which is a significant stress in the quads. So usually we make this diagnosis by clinical exam. X-rays are not indicated unless the patient has unusual or atypical complaints, or the pain is not directly over the tubercle. But usually you can make the diagnosis with your exam. So here's an X-ray, something you might see. See the tibial tuberosity here, the tubercle there, and you can actually see some soft tissue swelling here. So the treatment, as I mentioned, is pretty conservative. Rest, although most of these kids won't rest because they won't give up the sport they're involved in. So you have to teach them to ice before and after, especially, and they can use NSAIDs. Some stretching of the quads and hamstrings may help. But short of that, this is usually a problem that they outgrow. All right, now we're going to move on to the adolescent health visit. So again, the point here being that adolescents require special treatment, and that the health supervision should be different than it would be with a younger child or even with a young adult. So it's important for you to realize that generally adolescents avoid the doctor. And what does that mean for you? It means for you that on the exam, anytime the adolescent presents, regardless of the reason, you need to provide health supervision and counseling. And the reason is because you're not going to see them in the office. So you need to take opportunities when you do see them, when they present to the emergency room or they present to you for acute care, to make sure that their health maintenance is up to date and you're providing some health supervision. School-based health clinics have been quite successful because they see the kids where they're at. So that's one of the best ways to provide treatment, is to get them the treatment at the place where they live. So school-based clinics have been very popular for that reason. So things to think about that are especially important that the boards tend to focus on. A big one is advocacy. That is you as the pediatrician being an advocate for the patient. Health promotion, early intervention, especially in preventable diseases. A psychosocial assessment, which is especially important in adolescence. Personal safety. We'll talk a little bit about motor vehicles, about substance use, about handguns, that kind of thing. And certainly around a conflict resolution. That's a huge issue, is trying to help teach your adolescents an effective way to resolve conflict. So let's talk a little bit about autonomy. What degree of autonomy should you give an adolescent patient? And I think the simplest answer is you should give them the degree of autonomy that their development deserves. So it's not age dependent. I think it's important for you to try to get away from, oh, they can't make any decisions till they're 18, and then on their 18th birthday they can suddenly make all decisions. That's clearly not the way it should be handled. So what the boards are going to look for you to do, and the questions that they might ask, is to grant the patient autonomy that they've earned through their development. And that's not age dependent, that's patient dependent. So you need to make an assessment about how well the patient can make a decision. How do patients make a decision? They have to be able to weigh the alternatives. They have to be able to understand the risks and benefits. So it's kind of going through the informed consent routine with them. And that's starting to help you understand what kind of decisions they're able to make. So you should allow the adolescent control within reason, and you should involve the parents, if possible, only as the adolescent wishes. So that is to say that you need to get into a routine where you're dismissing the patients from your interview with the adolescent at a very early age. So, I personally would recommend that you start at around 8 to 10 years of age, where you're actually routinely dismissing the patients from the room. That way, when you do it when they're 14 and the girl presents because she missed her period, you're not asking the parent to leave the room and they're like, oh my God, what's going on? It just is routine. This is something that you do all the time. So you need to be able to interview the patient alone. And you also need to tell the patient that there are limits of your relationship, that you will grant them the autonomy that they've earned, but you also need to attend to their safety. And so that can sometimes be a balance. The AMA says that physicians who treat minors have an ethical duty to promote the autonomy of minor patients by involving them in the medical decision-making process to a degree commensurate with their abilities. So again, this is just stating what we've already talked about. There are limits to autonomy, and you need to warn your adolescent patients that there are situations in which you will be required to breach that confidentiality or that autonomy that you've granted. And I've listed for you the situations that you might do that. But these are all situations that may lead to a significant threat either to the patient or to someone else. So adolescents are making a lot of difficult transitions. This is just a short list of the kinds of things that they're facing. And so many of the situations that you're going to be dealing with have to do with these transitions. So they're going from being very dependent on their parents to being independent. They go from a family focus to a peer focus. That's one of the biggest things that we'll talk about, is how that change to a peer focus impacts their health. They go from having generally very few choices that they can make to having suddenly lots of choices that they can make. So there are lots of important transitions going on. As you collect the history from adolescents and you talk with your adolescent patients, it's very important for you to use correct terms, avoid medical jargon if possible, to shift the focus from the patient. So what does that mean? Well, it's a lot easier for you to talk about, to get the information you need by talking about your patient's friends. It's a lot safer. Find out who they hang out with, find out what kind of activities they like to do. Ask them if they know people who are using drugs. Ask them if they know people who are having sex. That's a lot easier for them to interact with you on and talk about than if you directly ask them that question. It's going to be harder for you to get the information. And you know that their greatest influence now is their peers. So as you start to get a sense of their peer group, you're going to get a sense of what kind of issues are coming up for them. It's important to realize that the chief complaint that the nurse writes down on the chart may not have anything to do with why the patient's there. So they may give a chief complaint to get in the room, but they really want to talk to you about something else. So you need to be very open to that possibility. So let's talk about anticipatory guidance, things to talk to the parents about. A lot of your interactions around caring for adolescents are going to be interacting with patients around what's normal, what can they expect, how do they manage some of these difficult normalities. Lots of body changes, promoting a healthy adjustment, self-acceptance and responsibility for oneself as an individual. And then the next category is huge. Parents need to know that their kids are paying a lot more attention to what they do than what they say. And so how they model behavior is incredibly important for adolescents. And parents they don't realize this, and I think you need to bring it to their attention. It's things like, how do the parents resolve conflict? How do they handle anger? How do they handle frustration? What kind of drinking habits do they have? What kind of habits do they have around motor vehicle use? Do they wear a seatbelt? Do they drive responsibly? So adolescents pay keen awareness to this kind of stuff in their parents. And so the parents need to recognize that this is an important piece of what they're modeling for their kids. Again, with parents, it's important to let them know they need to make a transition. And that transition for them is speaking a lot less and listening a lot more. And so parents are not accustomed to this because they're used to their kids being kids. And so they're used to being able to and needing to provide a lot of direction. And they need to learn how to step back and speak less and listen more. Decision making, we'll talk a little bit about how to foster participation in that. So helping parents, again, tell them to establish just a few rules, just the important ones. So they shouldn't sweat the small stuff, and most of it is small stuff. So the more parents can get accustomed to not sweating the small stuff and just sticking to the big rules, they'll do much better. Avoid rigid control, use carrots more than sticks. Expectations are huge. Lots of communication between parent and adolescent around what the expectations are. And allowing the patient or the adolescent to participate in the discussions can't be overemphasized. So this is one acronym that I found that I thought was useful. It's called the Parent-Adolescent Contract, and it's about how to develop rules, how to develop understandings and expectations with your kids. And so participate, acknowledge that there are authorities that need to be respected. So whether it's school officials or police or the parents, there needs to be an acknowledgement on the adolescent's part that there are authorities that need to be, whose rules need to be followed. Mutual respect, encourage open communication. Negotiation is huge. So that always has to be a part of that discussion, is a back and forth and telling the parents you need to allow some latitude for the adolescent to negotiate what they want. And then tolerate each other's differences, because you know that that you have differences. All right, another question about counseling. This one's about counseling adolescents. So as a physician counseling adolescent patients, which of the following best describes the most effective approach? Is it A, use abstract concepts so the patient can practice this type of thinking? B, be concrete using specific facts not open to interpretation? C, use visual aids sparingly? D, provide multiple handouts so the patient has something to take home to read later? Or E, repeat instructions several times? Which is the best choice in counseling your adolescents? Good. So I like your choice. You know, I think it speaks to the fact that you need to think about where your adolescent is at. And older adolescents obviously are going to be able to abstract and use higher level concepts. But certainly the take-home message is during your discussions with adolescents, you need to be very concrete. You need to use very specific facts and information that aren't open to interpretation. So that is the best way to do it. The others, are things that can be done. Obviously, visual aids can help, so that's C is probably not a great answer. Handouts, the literature shows that even with adults, they don't read that stuff. So, it's great, and we all do it to sort of make sure we cover our butts. When we send people out the door, we can give them instructions, it's written down, and we can put it in the chart, and we say we did it, but people don't read that stuff. And there's really nothing that's going to drive an adolescent more crazy than repeating things over and over. Some high-yield topics on the boards are going to be injury prevention and safety, especially seatbelt use. We talked yesterday about helmet use. That's huge. So almost any physical activity for which there's a risk to head injury, a helmet should be worn. Conflict resolution is giant. I mean, that just can't be overemphasized as a topic that's going to be stressed. Teaching adolescents how to effectively resolve conflict without using violence or weapons or other things that are going to lead to harm. Adolescent depression is a hot topic. Adolescent nutrition has always been important. That's not new. Substance abuse, same thing. Just need to think more and more about how many kids are using these substances and when they're getting exposed to it, and giving them tools to handle that exposure. Social relationships and sexual activity. And the one I didn't mention, steroid use or over-the-counter drug abuse is becoming much more prevalent. And I was reading not long ago in some of the popular literature, there's this game that's become popular where the kids get together at a house where the parents aren't home. They go into the medicine cabinet and they put all the pills in the medicine cabinet in a bowl, and they mix all these drugs, dump them in a bowl, and then the game is you take a handful and down it. And that's, as you know, that's incredibly dangerous. And obviously, if you're going to do something like mix it with alcohol, you're talking about a serious hazard. So you need to be aware that it's not just drugs that are illegal. One of the biggest problems now is abuse of prescription drugs. And they're not drugs that have been prescribed to these adolescents. They're drugs that have been prescribed to their parents. So best thing to do is tell the parents to throw those drugs away. We're told, you put them in the garbage now. You don't flush them down the toilet. You put them in the garbage. But you shouldn't be keeping old meds around the house. And if you are, they shouldn't be in an accessible place. So important topic to talk to the parents about. So HEADS is a common phrase that's used when we're talking about how to remember what to talk about the psychosocial assessment with adolescents. It's a very important part of the history. So when you're taking your history, you're probably used to sort of equally spending time on the various parts of the history, the past medical history, the present illness, and so on. But with adolescents, you need to be spending the majority of your time on the psychosocial assessment. And this is just something to help you remember what to ask. All right, some physical exams and screening tests that are new for the adolescent exam. You need to start transitioning to the adult genitourinary exam. With your young female patients, you need to be teaching appropriate breast exam. It's important to teach this early as a part of good health. Promotes self-awareness. It's a skill that they're going to need later in life. I will tell you that there is some disagreement about this in the literature because there's concern that you're raising anxiety about cancer, breast cancer, in patients for whom the risk of breast cancer is near zero. So you need to just reinforce that with your patient, that this is just a good habit, that you're teaching them, that you're not worried that anybody's going to develop breast cancer as an adolescent, but you want to teach them good life habits. Obviously, the pelvic exam and the scrotal and testicular exam are important. Boys do, in fact, need to learn how to examine their testicles, and you need to show them. And in fact, contrary to the situation with breast cancer, who gets testicular cancer? It's young males. So young males. So that's really important for the boys to learn. And that is a disease where early detection clearly leads to a much better outcome. Bright Futures, again, is going to be a great source for you. So again, I encourage you to go to their website. All this information is there, but you need to have a really good sense of who, when, and how you screen for all of these things. And again, looking at the fine print in the guidelines is a great way to figure out whether or not you know the material. All right, a question about screening in adolescence. Grab your box and answer the question, which of the following is correct regarding screening recommendations for adolescents? So 4 of these are wrong and 1 is right. So A is screen all sexually active females for chlamydia during routine pelvic exams. B, screen all adolescents once for renal disease with analysis of a first morning urine specimen. C, screen all adolescents between ages 10 and 12 for high cholesterol. D, screen all adolescents between ages 10 and 18 for TB with an annual PPD. Or E, screen all adolescents for anemia before age 12 with a hemoglobin. So go ahead and grab your box and answer that question. So, you know, as I went over this question yesterday, I realized that it could be confusing for a couple different reasons. So let's talk about that. A is correct. You should screen sexually active females for chlamydia during routine pelvic exams. That is correct. But C is going to be discussed during the cardiology session, so we don't need to worry about that. But I'll tell you that C is more targeted screening. So it's not universal screening. For B, we talked yesterday about how we're not using urinalysis for routine screening at all anymore. D, screen all adolescents for TB. We don't do that except in high-risk populations. And then E, there's one interpretation to E. Well, you're asked to screen all kids, right, when they're younger, but you're not asked to screen adolescents specifically for anemia. Again, it's targeted screening for anemia specifically for menstruating females. So it's not all adolescents. So as long as you understand the reasoning behind your answers, you'll be fine. So for TB, we only screen adolescents at risk, not the general population. So who's at risk? People who are incarcerated, people who are living in homeless shelters, and that kind of thing. You need to be aware of the risk factors for tuberculosis so that you can invoke screening when it should be. Anemia is screening just the menstruating females and others who might be at high risk. And cardiology is targeted screening, but cholesterol is targeted screening, and that will be discussed in the cardiology section. All right, so we're up to growth and development. First question, which are the first signs of puberty? Is it A, menarche for girls and first semen emission for boys? Is it B, clitoral enlargement for girls and penile enlargement for boys? C, breast buds for girls and testicular enlargement for boys? D, the appearance of pubic hair? Or E, the appearance of axillary hair? So which is the first sign of puberty? So grab your box and make a choice. All right, so we're all on track for that one. It suffices to say that for the test, you need to memorize some of the features of the Tanner stages so that you can identify the stages, because you're almost guaranteed to get a question on this, where they're going to show you a picture, or they're going to describe a figure, or they're going to describe a patient. Remember, there's no Tanner stage 0. But you need to know sort of what's represented by these 5 changes. So I've actually written out all the stages for you, and there's 5 for each, boys and girls, and we're not going to go through them, but what you need to do is, in your mind, make sure that you have a pretty good sense of how it's changing over those 5 stages. And the Tanner stages are probably the best way, the best mechanism to assess where a patient's at in their growth and development. So the boards are going to expect that you use Tanner staging to assess where a patient is in their growth and development. All right, the developmental stages of adolescence should shape how you interact with patients. And we've started to talk a little bit about this. We're going to talk some more about how it's going to shape how you interact with patients, how you provide counseling, how you structure their treatments, and how you set expectations. So normally in early adolescence, patients tend to be very concrete. Again, this is a situation where you want to use lots of facts that aren't open to different types of interpretation. You want to provide simple and very explicit instructions, and in your discussions, you should be accurate in your use of terms. Visual aids and verbal cues can help a lot. Always be open to questions about physical maturation. A lot of emphasis on who they're spending their time with, how they're spending that time, what kinds of activities they're engaged with, what their peer group is. They tend at this point to be very impulsive and have little appreciation for the consequences of their actions. So that's a pretty dangerous combination, right? Impulsivity without appreciation for consequences. Middle adolescence, puberty starting to draw to a close. They're starting to learn how to develop relationships with both genders. The peer group clearly dominates at this point, but they're starting to have a more of an ability to interact with the real world, but they still tend to be really impulsive. In late adolescence, this is where they start to become sort of idealistic. They're starting to shape their gender role and their identity and their feelings about their body image. That's starting to settle down a little bit. Now they're starting to gain, their individual relationships are starting to gain more importance, especially those with their best friends. So the peer group is still going to have an influence, but now they're moving into the sort of collegiate years where they're focused more on some individual relationships, and they're starting to develop a sense of shaping their life goals. So the rights of minors, we're going to talk a little bit about what rights minors have, and you need to be pretty familiar with this. So let's start out with a question. In most states, in all of the following situations except one, a minor is able to seek counseling from a physician without parental control. Counseling and assisting the patient with obtaining treatment for which of the following conditions typically requires parental control? Is it A, sexually transmitted infections, B, drug addiction, C, contraception in pregnancy, D, chronic disease, or E, mental health issues? So you're right, it's chronic disease. And that's sort of an interesting situation, but that of all the choices there is the one that requires the parent's involvement or the parent's consent. The other four, and the way to think about these things, the best way I think to think about them is if there's an element of the interaction you might have with a patient in any of those situations that involving the parents may lead to a less likely outcome of the adolescent actually seeking treatment for that situation, then the states recognize that is an impediment to treatment, and they're going to allow you as the physician to go ahead without parental consent. So in the other four, there's a perception that the requirement to involve parents in the treatment or the plan for those other four might be an impediment to the adolescent seeking appropriate treatment. And so that most states will protect that right. So self-consent is specified in state and public health statutes, but those typically include the situations which parental involvement may be an impediment to treatment. So sexually transmitted infections, pregnancy, contraception, substance abuse, mental health issues. All of this generally is controlled by state statute, and so you need to be familiar with what the rules are in your state. But the absolutes that the boards are likely to focus on are that you need to allow for autonomy to some degree that's commensurate with the patient's developmental ability. You need to make sure the adolescent is participating in the decision-making, even if the parents need to be involved. The adolescent needs to participate in that decision. and that you as the physician are always allowed to act in an emergency where life or limb is threatened. So you're always able to act regardless of parental consent or not if life or limb is threatened. So you're always expected to act in the best interest of the patient. So for the test, if parental notification is likely to impede the adolescent seeking necessary treatment, then the answer you should pick is the one that allows the physician to provide treatment without parental consent. Minors, what makes up an emancipated minor? If there's a specific condition that exists, minors are considered to be emancipated. So that is to say that they have earned the right to make decisions independent of their parents. So that is they've physically moved out of the home, that they're financially independent, which means they're supporting themselves, that they have married, or that they become a member of the military. Mature minors are a different group, one that's very, very important to consider. And this has everything to do with what we've been talking about, which is allowing minors to participate in decision-making that is commensurate with their ability. So mature minors are minors who have the capacity to understand the risks and benefits and the alternatives to a specific treatment, and they should be allowed to participate in decision-making. And if you create that situation, then the minors actually are in a situation where they may provide consent. Usually those are situations where there's little or no risk and a pretty clear benefit. Confidentiality. If a patient has the ability to self-consent, then they have the right to confidentiality. So that's the other piece that comes along with this. If you're going to decide that a patient's earned the right to self-consent, then they've also earned the right to your confidentiality. So I've listed exceptions: child abuse or potential harm to self or others. And then there are, again, special state rules. So be aware in your state about rules around, for example, abortion and pregnancy. We mentioned before that adolescents aren't seen much in the office. So school-based health clinics make a lot of sense, but oftentimes the emergency room is the only place that adolescents end up going. Oftentimes it's for non-urgent care that they're being seen, but the leading complaints are injuries, abdominal pain, and sore throat. The answer to look for on the exam is that the boards are always going to want you to provide counseling and advice and anticipatory guidance, because you need to recognize that this is the only time that the adolescents are being seen. So the adolescent may present with a significant ankle strain or sprain, and what's the answer on the question? The answer on the question is make sure that they've had their Tdap or that their MMR is up to date. So just be aware that they're going to throw some curveballs like that. So the important causes of morbidity and mortality, which is what should direct how you provide preventive counseling. We talked about motor vehicles, homicides, HIV, so protecting themselves in their sexual activity and advising them about the risks of drug abuse is very, very important. We're going to talk a little bit about sexuality and contraception. Perhaps surprisingly, 50% of U.S. high school students report that they've had sexual intercourse. So of those high school students you're seeing, half of them are engaged in an intercourse. And it's important for the pediatrician to be involved with these patients in counseling, support, helping prevent disease, and potentially diagnosing any consequence to their sexual activity, including infections, pregnancy, and any possibility of sexual victimization. So another question for you. When is an adolescent female most likely to initiate a discussion with a physician regarding contraception? Is it A, at the urging of her parents, B, with menarche, C, before the first sexual encounter, D, soon after the first sexual encounter, or E, 6 months after the initiation of intercourse? Which of those is correct? Okay, so we have a little split decision here, but the majority wins. In fact, it's most likely 6 months after the initiation of intercourse. So you can't wait for the patient to come to you, because by the time the patient comes to you to discuss this, it's too late. So the average lag between first sexual intercourse and discussion with a physician is 6 months. So you need to start your counseling at age 10. Just needs to be routine. And discussions frequently occur during a visit for a missed period. That's obviously way too late. So I've indicated for you a chart here that shows you the methods of contraception and how well they work in theory, which is if practiced perfectly, and in practice. So it shows you some pretty big differences. So, for example, a good one is oral contraception. In theory, it's close to 100% effective, but in practice, it's only about 90% effective. And the reason is because the patients forget to take their pill. So you can see that there are a variety of methods that are available to patients. Patients need to be informed of their choices, and you need to help them pick an appropriate choice. Always recommend condoms in every situation, regardless of whether other birth control is used or not. It helps reduce the transmission of sexually transmitted infections. Emergency contraception. So some of the topics, again, sort of like yesterday on the social topics, we're going to be talking about things that are politically controversial. And so it's important for you to understand what the position of the American Academy of Pediatrics is on some of these issues so that you can represent those on the exam. Emergency contraception is one. Emergency contraception actually is very effective at preventing pregnancy. So what is emergency contraception? It's where you're taking basically high-dose hormones after intercourse to prevent the pregnancy from being successful. It's also called the morning after pill. It's available in several different formulations, but there is some discussion about even whether it should be available over the counter. And currently, the AAP supports improved availability of emergency contraception, access over the counter, and the AAP opposes any limitations to that access. So there were some states I read about where pharmacists were getting together and deciding they weren't going to allow these prescriptions and so on. Basically, it's important for you to realize that the AAP wants wider access to this, and they believe that adolescents who make a decision to use it should be able to get it. The literature does not support the concern that's often expressed that widespread emergency contraception use encourages unprotected intercourse. It's simply not true. And that this form of preventing a pregnancy is actually pretty effective. So the earlier it is applied, the better, the more effective it is. And so a situation might be on a question where you're receiving a call in the evening from a patient who tells you that she just engaged in intercourse, in unprotected intercourse, and she wants to know what to do. And so this is an option for her. The side effects are related to the fact that basically you're asking the patient to take a large dose of hormones. So any of the side effects that are typical along with that kind of administration of that kind of medication, nausea, vomiting. All of the patients, of course, are going to have menstrual irregularities, but other things can be fatigue, breast tenderness, headache, abdominal pain, and dizziness. There are some significant contraindications, and these are all the same contraindications as would apply to a patient who's considering hormonal contraception. So you need to think about this list before you prescribe any sort of hormonal contraception. Okay, we need to talk about homosexuality, and why is this relevant? It's relevant because for as long as it's been possible for us to measure, it's been pretty consistently shown that between 2 and 10% of the population is homosexual, that homosexual adults are parents, that homosexuals, there are adolescents who are homosexuals, and that adolescent homosexuals experiences put them at higher risk for certain problems and issues. And so you need to be aware of those. What's been shown is that there are millions of children in the United States who have one or more parent who's homosexual, and the data shows that these children are just as well adjusted as the general population, and that there is no increased risk for any gender identity problems or other issues around sexuality in children who are raised by homosexual parents. Adolescents who are homosexual are at higher risk for being homeless. They're at higher risk for physical attacks. They're at higher risk for suicidal thoughts and eating disorders. So you need to be aware so that you can provide the kind of support that these patients need because they are at higher risk for these problems. So you should counsel homosexual adolescent patients in the same way you do all adolescents. You should help them accept who they are, help them develop healthy relationships with other people of both genders. You should foster their individual responsibility for their relationships, their actions, and their future. All right, we're going to talk a little bit about the media. And the media, as you know, is prevalent, and kids are exposed early and earlier to sexual activity, to violence, and the AAP believes strongly that pediatricians and parents and families need to take responsibility for this. There is a link between media violence and aggressive behavior. It's been shown through a variety of different studies that people who are exposed to media violence are more likely to exhibit that violence. So it clearly has an impact. The AAP recommends that this public health problem is addressed through open discussions where parents and pediatricians help patients make good choices, that they agree upon mutually acceptable content, and that there are discussions about what the kids experience in the media. So it's important for the kids to have the opportunity to talk about this with adults. Sexual interest in adolescence is normal, and a lot of times you need to help parents recognize that. And the AAP never dictates norms. It basically says, you know, we recommend a family focus, and we recommend open discussion, and we recommend pediatricians be involved. So advice you can give to parents, they can do what you ask them to do with a lot of other situations, which is sit down with their child and negotiate what's appropriate media and what's inappropriate media. If you can, to co-view, that is to say that if your kid wants to go to that R-rated movie and you decide that you're going to allow that, then go with them and watch the movie together and afterwards have a discussion about it. I tried that with Borat. It didn't work out so well. You should discuss content that they're being exposed to and what their concerns are about it. You need to teach critical viewing skills. So you need to help the adolescents understand, you know, how they're going to look at this media and what's important about how it might impact the way they behave. Parents should limit time, emphasize alternative activities. So we want to push kids away from the couch and out onto the soccer field. Keep the bedrooms media free. That's a simple rule that the parents can establish. No computers, no TVs in the bedroom. And avoid the use of media as a babysitter. So recommendations from the AAP. This is a public health risk. That you should question parents as a part of your routine history. You know, where is media in the home? How is it used? How are the kids using the media? General recommendation, no exposure for kids under the age of 2. Advise parents to model appropriate media use of them, you know, their own use of television and computers. Suggest that parents not purchase media that they judge to be harmful, and promote healthy alternatives. Okay, firearms. Firearm-related injuries are also a significant public health problem. So the most effective measure is to take guns out of homes. Now, for some parents, that's not going to be an option, and if it's not, then as we discussed yesterday, Best thing is to make sure that the gun and the ammunition are locked up and they're separate, away from a place where a child might get access to them. All right, substance abuse. Smoking and drinking problems. Mean initiation of alcohol and tobacco use is 12 years old. Boys are more likely to drink. Girls are more likely to smoke. But there are other drugs out there too. 50% of adolescents report marijuana use. Mean age of use at first use is 14 years. And 10% of adolescents report cocaine use. So here are some of the signs of drug abuse that you might find in patients. But as you look at this list, the problem is some of this might be associated with normal adolescent development. So you have to sort of tease out what the pattern is. One of the most important things is to look for a change in interest group. So a flag on the exam might be that this adolescent comes to you, and last year you saw her, and she was, on the soccer team, and she was really involved in student council, and she had a bunch of friends that she described the kinds of things they like to do that were all pretty benign activities. And the next year she comes and she's quit the soccer team, and she didn't run for student council again, and she's got a new peer group, and she describes to you different friends than she had before. That's a serious red flag for drug abuse. But these other things obviously are things that should pique your interest as well. So you should think about the fact that you can't provide any sort of testing without the patient's consent. And again, this needs to be a discussion between you and the adolescent that may or may not involve the parent, depending upon the adolescent's view of things. But your focus should be on identifying the problem and identifying it as a problem, getting the patient into a situation where they can early on create a situation where they stop using the drug, and it's not punitive. So you've probably heard of the CAGE questions. These are 4 simple questions you can ask that have been shown with patients, largely with adult patients, but I think it's effective with adolescents as well. Any single positive answer to any of these 4 questions is a positive screen. Now again, remembering the difference between screening and diagnosis, these are used just to screen whether or not you need to be more aggressive in your seeking information for a diagnosis of an alcohol problem. So if you ever felt the need to cut down on the amount of drinking you do, if you have felt annoyed by criticism of your drinking, if you had guilty feelings about your drinking, and if you ever taken a morning eye-opener, that's taking a drink to chase off a hangover. There's another one called CRAFT, which is a way of screening for substance abuse in adolescence. I think this is particularly helpful. It opens up the discussion on a lot of different elements that you should be thinking about. Riding in a car with somebody under the influence, using drugs and alcohol to relax or to address feelings of anxiety or something else where patients may be using these substances to self-treat. Do you use them alone? When you're by yourself, are you using alcohol or drugs? Do you forget things while you're using them? Do you go through that's kind of a blackout where you don't remember things? Or do you tend to get into trouble after using them? And again, any single positive response is considered a positive screen. All right, so eating disorders, a topic that we have to talk about relative to adolescence because the incidence of eating disorders, both anorexia and bulimia, are significant in this population and seem to have increased in the last century. There does seem to be a genetic predisposition, so that's just something to be aware of in the past history, if that's significant within families. The biggest risk factor is transitional periods, and especially moving from one school to another. So the highest risk for these patients is when they're changing schools. And that depends on your school system, but the kinds of times that that's happening is going from 5th to 6th grade or going from 8th to 9th grade. Those are times when they're changing schools, put them at particularly high risk. And One flag that you might see in a question is the patient makes an announcement that she's decided to go on a diet in spite of a normal BMI. Anorexia occurs in 1 in 100 girls, so it's pretty prevalent, especially between the ages of 16 and 18. I showed you some peaks, but again, those peaks correlate with school transitions, right? So 14 years old, about the time that a lot of kids are entering high school. 18 years old, about the time a lot of kids are entering college. Girls outnumber boys 10 to 1. They tend to be overachievers, perfectionists. There's a lot of psychiatric comorbidities that you need to be aware of. On the exam, you want to look for the typical description of those who are very weight conscious. So gymnasts, ballerinas, ballet dancers, wrestlers, others for whom weight is a big issue. So what happens to the body? What happens to the body is it goes into a mode where it's trying to preserve calories and is trying to slow the metabolism to address the fact that there are significant caloric limitations. So patients tend to present with bradycardia, hypokalemia, that's often from their vomiting, hypochloremia from the metabolic alkalosis, and they tend to abuse laxatives and diuretics and self-induced vomiting. So you might be presented with a description of the patient that has these kinds of parameters and asked what the diagnosis is. So make sure you think about eating disorders. The key to treatment is early intervention. In severe anorexia, you may require hospitalization. Patients can get into situations where there's significant morbidity and mortality associated with the anorexia. Bulimia is actually more common than anorexia, and patients may have both, either simultaneously or alternating. Patients with bulimia tend to be either of normal weight or may even be slightly overweight. So the really thin person is not the flag as it is in anorexia. So this might be a patient of normal weight. And you need to think about how they might present with fatigue, bloating, irregular menses, or a sore throat from their recurrent vomiting. On the test, you can look for some physical signs. Some physical signs are swelling of the parotid gland from the vomiting. They actually can get calluses on the backs of their knuckles from putting their fingers in the back of their throat. You can see loss of tooth enamel from the acid in the vomitus. So there are some physical signs to look for as well. Other clues for recurrent vomiting and self-induced vomiting is aspiration pneumonia. Syrup of ipecac abuse can lead to hypokalemia and an increased or irregular heart rate. And then we talked about the alkalosis, and you can actually see amylase levels go up from the vomiting as well. Okay, obesity. So there are 3 ways to define obesity in adolescence. Weight greater than 120% of the median weight for height, excess triceps skin fold. So there aren't too many people do that, but that's the fold of skin under your triceps. And then the body mass index. The guidelines have been fairly recently revised, and we talked about these yesterday, but it's based mostly on BMI. You're being asked to assess diet and physical activity for every well-child visit. So that should be part of your routine. And we're being asked to focus on getting some sort of treatment in place for those above the 85th percentile. And what does that treatment involve? Well, as you know, obese kids tend to come from families that don't have good habits. And so that has to be part of your treatment, is getting the entire family involved. So the social system is incredibly important. Very few of us in modern society eat when we're hungry. Most of us eat as a part of habit. It's time to eat. We eat when we're sad. We eat when we're happy. We eat as a reward. So eating is not to fulfill hunger anymore. And so a lot of what your treatment needs to focus on is eating as a behavior. Increasing caloric expenditure and decreasing caloric intake, Those are simple principles. And simple things can be done to get patients started. So having them walk for some exercise, having them try to avoid high caloric food, reducing saturated fats, trans fats, and cholesterol is all important. Many of you have probably heard of the so-called metabolic syndrome or syndrome X. This is the syndrome in which that involves obesity, dyslipidemia, and hyperinsulinemia. And you get the insulin levels so high that you get this insulin resistance, and it becomes a vicious cycle, right? Because insulin is pro-metabolic, and so if you develop insulin resistance, you're producing more insulin. Because of that resistance, you need to produce more insulin to get the effect, and insulin is very pro-metabolic, so it's going to make losing weight even more difficult. There are significant consequences: type 2 diabetes, high blood pressure, a prothrombotic state, a pro-inflammatory state, such as elevated C-reactive protein. These have all been measured in the metabolic syndrome. All right, another question for you on screening guidelines. This is the U.S. Preventive Task Force. So the U.S. Preventive Task Force now recommends which of the following? A, all children between the ages of 5 and 8 years of age be screened for attention deficit disorder. B, all children between the ages of 8 and 12 be screened for major depressive disorder. C, all adolescents between the ages of 12 and 18 be screened for major depressive disorder. Or D, all adolescents between the ages of 12 and 18 be screened for anxiety disorder. Which of those is a U.S. Preventive Task Force guideline? So there's new screening guidelines for depression, and we need to talk about that. So the U.S. Preventive Task Force now recommends screening for major depression for all adolescents between the ages of 12 and 18. They recommend a risk assessment of parental depression, some comorbidities, and that you talk to the patient about the possibility that there have been significant negative life events as a screening for depression. So there's no specific tool or test that's recommended, but there are lots that you can use that are pretty simple. I just gave you one example. The Beck Depression Inventory is pretty simple. Patients can fill that out on their own, and it's a reasonably good screen. Comorbid conditions are very common with depression. So we talked earlier about patients using substances to self-medicate. That's often a problem, but also attention deficit disorder or disruptive behaviors, anxiety, all associated with depression. So important to screen for those as well. 9 flags that I listed for you for symptoms of depression in adolescence. And again, part of the challenge here is that any one of these may be pretty normal in the development of an adolescent as they adjust to this big task of becoming an adult. And so, any one of these alone may not be worrisome, depending upon the context, but you need to carefully examine if any of these are present in your patient for the possibility of depression. All right, there are also medical conditions that can mimic depression: hypothyroidism, some nutritional deficiencies, chronic infections like mononucleosis and HIV, both of which unfortunately are relatively common in the adolescent population, chronic systemic illnesses such as lupus or others, and then we talked about substance abuse. So that certainly a substance abuse problem can present as depression. Treatment, just like many of the other things that we've talked about where problems are related to social situations or multidimensional, it's very important for your treatment approach to be multidimensional as well. So you need to look at getting others involved. You need the help of social workers, psychologists, teachers, counselors at school, and so on. Medications can be very effective. The SSRIs are very good. However, they take some time to really take effect, and you may need up to 6 months to really understand how the medication is impacting the patient. Tricyclic antidepressants are not used quite as much. They have some significant side effects and complications that you need to be aware of, so the SSRIs seem to be used a lot more. All right, we're going to separate out some issues now between males and females and go over some of the concerns that you're going to face with your adolescent patients. First, let's start out with a question about gynecomastia. So which of the following is true about adolescent male gynecomastia? A, it occurs in less than 10% of boys. B, it usually occurs before the age of 10. C, the breast is usually somewhat tender. D, both breasts are usually involved. Or E, medications are indicated to reduce the gynecomastia. What's the best choice there? Okay, so the most popular decision about this was C, that the breast is usually somewhat tender, and that's true. So we'll go through and look at each of the other answers. So male gynecomastia is very, very common. Up to 50% of boys between the ages of 10 and 16, most commonly around age 14, have some degree of gynecomastia. And for those of you who are seeing patients of this age, you know that this is incredibly distressing to them. So it is something that you're going to have to address with them. It's believed to be caused by a decreased ratio of the androgen to estrogen and a change in the sensitivity of the breast tissue receptors. Typically is somewhat tender, usually asymmetric, but emotionally very traumatic. Almost all cases resolve spontaneously within 3 years. So there's no treatment that's necessary, but lots of counseling. Some less common causes that may be related to medical conditions, Klinefelter syndrome, anabolic steroid abuse, tumors, drug use, especially marijuana has been associated with the development of gynecomastia. Scrotal swellings and masses, we're going to spend quite a bit of time talking about this. And part of the reason is because you need to know how to discriminate on the exam between an emergency and something that's not an emergency. And that can be done. So let's start out by thinking about how these can be divided in the big scale of things. One way to do it is the 3 different groups that I've classified things into. The cause or source, so that's congenital and acquired. And almost all of the acquired problems are infectious diseases. 2 is the timing. Does it tend to be, is it acute or is it chronic? And then 3 is whether pain is present or absent. And I think if you sort out those features in your mind about each of these situations that we're going to talk about, you'll remember how to handle the question on the exam. So I put together a little table for you to help with that. This is typical timing and pain patterns. But what you'll notice is that, that hernia is in all 4 boxes. So hernia can present almost any way. And so that always needs to be on your differential. And the most important is sort of understanding that most of the acute problems that tend to present are painful, and that most of the chronic ones that are in this box down here tend to be painless. So that's a good way to sort of sort out these different things in your mind. Now, does that help you sort out which is an emergency or which needs more aggressive treatment and which doesn't? No. Unfortunately, it doesn't. So we'll talk about that. So getting the history on a scrotal mass, you need to ask about timing, whether it's painful or not, and if it's painful, the location and intensity. Is there a change with position? So most important one that changes with position is a hydrocele. Very common scrotal mass, often presents with a change in position. Whether or not there was trauma is an important question to ask, and any other associated symptoms like fever. The physical exam, location of the mass, whether or not you're able to isolate pain to a certain part of either the testicle or the associated structures in the scrotum. You can sometimes actually see erythema. And then testing the cremasteric reflex is an important technique to be able to use because it'll help differentiate a number of different problems. And I listed for you the normal cremasteric reflex just as a review. A congenital scrotal mass could be a scrotal polyorchism, a scrotal rest, which is scrotal tissue that is abnormal tissue, usually from other organ systems like the spleen, the adrenals, and others. Treatment usually involves non-urgent surgery. For acquired scrotal masses, I give you a pretty long list, and we're going to talk about each of these independently. So you need to have some understanding of each and how they present. So think about what that might be. So that's a pretty good-sized mass. It's not associated with the testicle. It's independent. You can see there's a connection up in the superior pole. Doesn't involve the vascular supply. So that's a hydrocele. Very common, and as I pointed out, it tends to be associated with changes in position. So the patient will tell you typically that when they're laying flat, they don't notice it, but then when they've been standing for a while, they notice this mass in their scrotum. So all of the following are true of hydroceles except one of these. So pick one. Is it hydroceles A, hydroceles are painful? B, hydroceles transilluminate? C, hydroceles may be confirmed by ultrasound? D, hydroceles usually do not require treatment? E, the size of a hydrocele typically increases with standing and decreases when recumbent. So all of the following are true of hydroceles except one of these. Which one? Grab your box and make a choice. Excellent. So you were listening for the last few minutes. That's good to hear. Good to see. So hydroceles generally are not painful. So the patient will tell you, this doesn't really bother me, except I get a little concerned that after I've been standing for a while, I have this big mass in my scrotum. Asymptomatic, painless, decreased with recumbency, and they do transilluminate, but that's not particularly specific. Okay, what are we dealing with here? It's an abnormal dilatation and torsion of veins, sometimes described as a bag of worms. It's a varicocele. It's idiopathic. Nobody knows what causes it. On the physical exam, the question tends to highlight that it feels like a bag of worms, increases with Valsalva. So if you ask the patient to Valsalva, you might notice it more. And then you may have to engage in surgery if it's affecting the development of the testicle. All right, this is a very common question that you'll be presented with on boards, and it's going to ask you to make a decision about how to manage a patient that has a testicular or scrotal problem. So late one night, a 16-year-old boy arrives in the emergency department complaining of 45 minutes of severe right testicular pain. He feels nauseous. He has no history of trauma. His cremasteric reflex is absent. The most appropriate action is, so this is what they call a double jump question, right? So you need to make the diagnosis first, and then you need to pick the right treatment. So the most appropriate action is A, prescribe a 10-day course of antibiotics and analgesics after sending a urethral and urine cultures. B, call the ultrasound technician in from home for a Doppler ultrasound. C, recommend scrotal elevation, application of an ice pack, and rest. Or D, arrange emergency urologic surgery. So pick one of those treatment courses. Okay, so most of you want to call your urologist, and some of you want to call the Doppler technician in from home. So the good news is you're both right. I think that probably D is a better choice because you've already been told in the question that the patient reports that this has been 45 minutes of severe pain. So sort of you're approaching the limits of the viability of the testicle at this point. And so if your ultrasound tech can be in 5 minutes, It will help you with a definitive diagnosis. But if there's any question about whether or not the ultrasound tech can get in and get the test done within a very quick period of time, choice D is right, because you need to just proceed right to the possibility of surgery. So the question with acute scrotal pain is always going to be surgery or not. And the answer is not always surgery. So there are situations in which inflammation in the testicle can lead to acute scrotal pain, and that can be treated medically and shouldn't be treated surgically. So your task in sorting out how to handle the question has to do with whether or not you're going to go to surgery or not. So 60 minutes is sort of thought to be the limit when a patient presents with some compromise to the arterial supply to the testicle. So the best thing to do is simultaneously prepare the operating room, even if you are going to get your diagnostic modality in time. So if you were going to call the technician in, you'd also want to call the urologist and say, I'm calling in the Doppler technician for an emergency ultrasound of this boy's testicle, but I need you to also get in your car and get in here in case he needs to go to the OR. So for the differential diagnosis of the acute scrotum with no history of trauma and no history of a pre-existing mass, I listed for you the 6 things that you need to think about. And some of them need to be treated medically and some need to be treated surgically. And you need to sort that out. So 1 and 5 are going to require treatment with surgery, right? So a torsion of the testis and a strangulated hernia are probably going to require surgery, whereas the others can be treated more conservatively. So we'll talk about the torsion of the appendix, but certainly epididymitis, orchitis, and a hydrocele all can more likely be managed conservatively without surgery. So one thing that can help you is the location of the pain. Acute epididymitis, you can actually feel a tender epididymis, so that's the area on the superior outer edge of the testicle. The patient may actually help you isolate the pain to that site, and that is almost always infectious disease. Torsion, the testicle itself is going to be tender, and that's your surgical emergency. And then torsion of the appendix of the testis, you're usually going to have some tenderness about the superior pole of the testis, but not the testicle itself. And so here's a schematic representing torsion, and you can see the concern obviously here is with the compromise of the arterial blood supply to the testis. Here's the epididymis, and so in epididymitis, that's where you're going to have the tenderness. So the patient's history that's typical in torsion of the testicle is severe pain that was very sudden. You may have some swelling of the testicle. The pain generally in the testicle is so severe that the patient complains of nausea and vomiting, and you can't or don't elicit any history of trauma. In the physical exam with torsion, you have a swollen, tender testicle. Sometimes the testicle is pulled up. It's not in the relaxed position down. And most importantly, and you should always check this, the cremasteric reflex. And so it's not specific, but it's 100% sensitive. So what's the prognosis? It's related to the fact of how long the time lag is to the compromise of the blood supply and the degree of twisting of the cord. But this is a surgical emergency. So diagnosing by imaging, the radionucleotide scan or the Doppler ultrasound with showing decreased blood flow, both of those are appropriate diagnostic testing. But again, you're answering the question is going to hinge upon how quickly that can be done. A trained urologist can do manual detorsion, but you really don't want to entertain that possibility without being ready to undergo surgery. And surgery, they detorse, untwist, and they do orchopexy, which is where they tack the testicle down so it can't twist again. So some differences between the torsion of the cord and the appendix, the testicular appendage. This table shows you that the two are treated differently, but the important thing to note is that one is a surgical emergency and the other is not. So one compromises the blood supply and the other does not. So with torsion of the appendix testis, what you're more likely to see is pain at the upper pole of the testis. You might see a pea-sized swelling at the upper pole, sometimes referred to as a blue dot sign. You can actually see that on physical exam. The best way to make this diagnosis is through Doppler ultrasound, and this can be treated with analgesics using things like NSAIDs. Usually spontaneously resolves in about 10 days. We talked a little bit earlier about tumors in the testicle, but this is a significant problem in young men. This is when testicular cancer arises, and so it's important to make the diagnosis early because that has an important impact on the success of treatment. So survival overall is about 70% with testicular cancer. It's 95% if you catch it in its earliest stages. So early detection is very important. We talked a little bit earlier about epididymitis. It's an infectious disease in adolescence. And I've listed for you some of the most common etiologies here. But they're all sexually transmitted. The presentation of epididymitis often presents like a UTI, so it's something you need to think about, but in your exam it's going to be very different. You should be able to pretty easily elicit tenderness about the epididymis. So the workup, again, is you're working up a sexually transmitted disease. So urine analysis, gram stain and culture, a swab of the urethra, any discharge or a urethral swab, especially for GC and chlamydia, usually gets you the diagnosis. Orchitis. Orchitis is a swelling of the testicle itself, and the patient usually presents with a tender testicle and some fever. And the workup is basically the same as epididymitis, although this is not always a sexually transmitted disease. So mumps is something we don't see much anymore because of the immunization, but it used to present as a complication of mumps with sometimes the development of orchitis. All right, so we're going to talk about some female issues. Breast asymmetry, just like the gynecomastia in the boys, the breast asymmetry in the girls is a very common concern. It can persist into adulthood in about 25% of patients. No intervention necessary, but just like the boys, lots of counseling, lots of reassurance that this is a normal phenomenon. Okay, we're going to talk a little bit about breast masses, and we're going to start with a question. So the following are all true of adolescent breast masses except one of these. A, almost all lumps greater than 99% are benign. B, discovery of a lump can cause undue anxiety. C, lumps commonly cycle. D, most lumps resolve without intervention. Or E, fibrocystic change in this age group is uncommon. All of these are true except one. Which one is untrue? All right, so fibrocystic change in this group actually is very common. So, and that's one of your challenges, is discriminating in your breast exam between fibrocystic change and other causes of breast masses. So, as I mentioned before, there's a bit of controversy about teaching breast cancer screening in this age group. And so what you can do is just not focus on it as a breast cancer screening tool, but rather as something that's a part of good self-awareness and good general personal health. So there's lots of other value to teaching the exam, but you do want to strike a balance between provoking undue anxiety and teaching good health. So the management, the likely diagnosis in a breast mass in an adolescent is a common cyst, which can be you can wait for any management over at least one cycle. So if there's change in the breast mass over that cycle, it makes you much less concerned that it's a mass of concern. If you're going to image an adolescent breast, you use ultrasound. Okay, so don't get a mammogram. All right. And the reason you don't get a mammogram is because adolescent breasts don't have a lot of fat in them. So your mammogram is not going to be helpful to you. So if you're interested in a diagnostic technique, you go to ultrasound because you're interested in whether this is solid or cystic. That's basically your decision point. And if it's cystic, then you may go to an aspiration. And if you go to an aspiration, all you're interested in is the cell type in the aspiration and whether it's bloody or clear. And so those are the things that are going to help you most in making diagnosis of breast masses in adolescence. So there are breast masses that don't regress or don't change with cycles. Those tend to be fibroadenomas. They're described as painless and rubbery, smaller in size, and they don't have any malignant potential. So when do you refer a breast mass? Persistence of a mass or enlargement over 3 cycles, or if you aspirate the mass and it's bloody. Cancer is extremely rare, and adolescent breast masses are very common. So you have to balance that. That isn't to say that breast cancer doesn't occur in adolescence. It does. About 1% of breast cancers do occur in women less than 25 years old. These tend to present as a hard, fixed mass, sometimes overlying skin changes, and a family history is really, really important for you to collect, especially now that we're able to run the breast cancer genes. But recognize that in only about 6% of those with breast cancer, there's a breast cancer-associated gene. So it's still very low. It puts you, if you have the gene, it puts you at extremely high risk. But most patients who have breast cancer don't have the gene. Mastitis. It's an infection in the breast. It's localized. It's more common in newborns. You've all seen it in the newborn nurseries every so often. And then that's thought to be exposure of the baby to maternal hormones. It can occur in lactating women. It's occasionally seen in a non-pregnant adolescent, but that should raise your suspicion for cancer as well as infection. So the treatment I've listed for you is usually pretty straightforward. All right, we're going to talk about some menstrual issues. And the first thing we need to do is look at all the actors. And here's the list of the actors in this complicated play. And here's the play. And what you see here is a lot of positive and negative feedback, a lot of cycles, a lot of interconnectedness. But it suffices to say that it's a very complicated system. For me, like as a visual learner, these kind of schematics are really, really helpful to me. So if you're also a visual learner, you might want to spend some time looking at diagrams like this to help you really understand the interplay of the various organs involved in the regulation of the menstrual cycle. So some simple reminders. The hypothalamus releases GnRH that stimulates the pituitary. FSH and LH from the pituitary then are released, and FSH stimulates growth of the follicles, and LH triggers the ovulation. Estrogen and progesterone. Estrogen peaks twice during the phases. One is the follicular growth phase, and the other is the luteal phase. And then progesterone, which is absent prior to ovulation, is critical in the luteal phase and also during pregnancy. The corpus luteum is that that develops after the follicle is burst, and the corpus luteum remains in the ovary and secretes estradiol and progesterone. And again, for those of you who are visual learners, this is a nice way to look at the cycle because everything is lined up. So what you have to remember is that ovulation, by convention, ovulation occurs in the middle of the cycle, and it shows you that menstruation starts the cycle. That's just convention. You can see here that there's a nice peak in body temperature, although it's not a big change because the scale here is just 1 degree. You can see the progression of the follicles maturing in the ovary, and then the development of the corpus luteum. And you can also see the changes in the uterine lining here in the various phases. So in the middle here is probably the most important to try to understand sort of how the various hormones play roles here. But you can see some nice peaks here in FSH and LH. You can see that progesterone has very little role or no role prior to ovulation, then a significant role after ovulation. So amenorrhea is best categorized as primary and secondary. Primary amenorrhea is the absence of menses by a certain period of time. And then secondary amenorrhea is the loss of menses after the patient has established a more regular cycle. So separating those out is helpful because the causes tend to be different. So for amenorrhea, for primary amenorrhea, the woman has never established a regular menstrual cycle. I've listed for you the many different possibilities to consider. But there are, as you can see, many of them are genetic syndromes, so you might need to engage in some genetic testing. There are others that might have to do with receptor problems or adrenal problems, so these are all important things to consider in primary amenorrhea. For secondary amenorrhea, this is where the patient has established a regular cycle and then stops having regular cycles. You need to think about things that might have changed. And so some of those things that might have changed are the level of exercise that the patient engages in, the amount of stress, anorexia. You know, one of the hallmarks of anorexia is the loss of menses, right? So that may even be the first presentation to you, is an adolescent girl presents to you having lost her menses, and you make the diagnosis of anorexia. So it's part of what the body does when there's this tremendous loss of body fat. But exercising lots, so marathon runners and women who engage in lots of exercise can have secondary amenorrhea. Other things to think about, polycystic ovarian syndrome, we're going to talk a little bit more about. Thyroid dysfunction, remember that thyroid dysfunction can cause just about any problem. So whenever you're presented with a problem, thyroid dysfunction needs to be on your list. The types of causes, we can talk about central causes, ovarian failure, and then anatomic causes. Central causes tend to be related to GnRH release from the hypothalamus, but I've listed for you possibilities like nutritional deficiencies and anorexia, stress. Some drugs will do it. There are other causes as well, like panhypopit or tumors. Infiltrative diseases are pretty uncommon, but it always falls on the differential diagnosis. And then pituitary infarction. Prolactinomas are actually relatively common, and they tend to cause amenorrhea. They can also cause, prolactinomas can also cause galactorrhea. And here's an MRI that shows you a prolactinoma. And then the ovarian failure as a cause of amenorrhea is another possibility to consider. And that can be just from a premature failure, infection, hemorrhage, or you can get actually an autoimmune oophoritis, which is an inflammatory situation in the ovary. Polycystic ovary syndrome is pretty common as well. It is, as described, it's a syndrome, so there isn't a single test that you can use to make this diagnosis, but it's a very common cause of secondary amenorrhea. Patients have a hyperadrenergic state that leads to anovulation, and one helpful marker is an FSH to LH ratio, but that's not diagnostic, so I just encourage you to realize that you can't make a diagnosis that way. It is, in fact, a clinical diagnosis. So anything that's going to increase androgens is going to create problems with amenorrhea, hirsutism, virilization, and I gave you some examples. Even thinking about exogenous anabolic steroid use is a really important question to ask of patients, whether or not that's a possibility. And then if there's anatomic amenorrhea, it basically means that the anatomy is not normal, and that's what's led to the amenorrhea. So a simple one is an imperforate hymen, but you can have vaginal atresia or malformation of the cervix or uterus that can lead to problems with usually primary amenorrhea. So how do you evaluate amenorrhea? Your usual complete history and physical. Try to isolate where in the axis you think the problem is, and use your testing to help you. And always include a pregnancy test. Always, always, always do a pregnancy test. So it's possible that primary amenorrhea could present with pregnancy. So patients never had a period and presents to you with pregnancy. So that is a possibility you need to consider. Clues to where the problem might be are related to androgens, estrogens, whether it's a possibility of a central amenorrhea. These are all listed for you, and you can see the typical androgenizing effects in patients. With estrogen, you might see some breast development, or vaginal mucosa shows estrogen effects. Those are all things that might give you clues as to where the problem might lie. And other signs of hyperandrogen states, acne, voice changes, clitoromegaly. Pelvic exam is always important to do to rule out anatomic causes. And the treatment, there are a lot of different treatments depending upon the cause. For PCOS, the polycystic ovarian syndrome, one of the best things to do is just to get them on the pill so that they can start cycling. And that's a very simple and pretty effective way to treat. Others are pretty specific to the cause of the amenorrhea. Dysfunctional uterine bleeding, very, very common. Vaginal bleeding that occurs in an unpredictable sort of way or cycle. And I've listed for you sort of how that's defined. It can often lead to anemia, which is obviously a problem. Again, we separate it out as primary and secondary. Primary is more common, secondary is less common. Secondary means it's caused by another problem. So usually that has to do with a clotting disorder. That's the most common cause of secondary. But for primary, it's usually an immature access, and usually just with the maturity of the access, the problem goes away. So it's common in younger women. For secondary, it's usually a disorder of coagulation. And you need to think about the possibility of underlying disease processes that involve the other organs within the system. But the most common one that might present as a bleeding diathesis is von Willebrand's disease. So problems with menses might be the first presentation through which you diagnose von Willebrand's disease. Anatomic causes I've listed for you: foreign bodies, hymenal tears, lacerations. Other problems: sexually transmitted infections, polyps, endometritis is usually the result of an infection. Just other things to think about for dysfunctional uterine bleeding. And the treatment is always directed at the source. So it all depends on what's the cause, but cycling with hormones is often one of your options. And then dysmenorrhea is also an incredibly common problem. Associated pain. It's one of the leading causes of school absenteeism. About 70% of teenage girls have dysmenorrhea. And what we know is that it's pretty treatable. Because we know it's due to prostaglandin production before menses, the best way to treat it is to use prostaglandin inhibitors. There's some knowledge that leukotrienes might be involved. The hardest thing is to get treatment started in advance of the dysmenorrhea, because the most effective way to treat it is to start the treatment before the dysmenorrhea starts. But we use cyclooxygenase inhibitors that block prostaglandin production, like ibuprofen and naproxen. Oral contraceptives can also be very helpful in regulating the cycle. Just the induction of oral contraceptives may solve the problem. In secondary dysmenorrhea, dysmenorrhea that's caused by other problems, infection. Obviously, an ectopic pregnancy is an emergency that might need to be dealt with, and endometriosis. The pap smears, I know you've had some discussion around this with one of your review questions, and there are a couple things that I want to drive home for you, and one is related to this question. So which of the following factors is most strongly associated with cervical cancer? Is it human papillomavirus infection, early sexual intercourse, chlamydia infection, a family history of cervical cancer, or a personal history of breast cancer? Which of those is most strongly associated with cervical cancer? Great. So the HPV, what we now understand is that cervical cancer is really a sexually transmitted infection. And so testing for HPV is an important part of your management. So it's the most common sexually transmitted infection in the U.S., and the vaccine's now available. It's now recommended for both boys and girls. And this, I'm going to actually point out to you, is the older version of the guideline. So as Tommy pointed out to you, there's a newer version, so some of the recommendations have changed. It suffices to say the bottom line is that we're probably doing more pap smears in young girls than we need to or should be. And so it's important for you to just be aware of the newest guidelines. High-risk patients, who's high risk for a pap smear abnormality? Anybody who's already had a pap smear abnormality, anybody who's HIV infected, whole different set of screening guidelines for people who are HIV infected. And if you've been exposed to DES in utero, that's less likely these days because hasn't been used since the 1960s. And just remember, it's not a screening test for sexually transmitted infections. Shouldn't be done during menses. A mucopurulent discharge is not a contraindication to going ahead with your PAP. You can go ahead and collect samples for culture as you routinely would, and it should be done as a part of routine prenatal care as well. If on the exam you're faced with an abnormal pap smear, test for HPV and then refer for colposcopy, because that's the best way to make a definitive diagnosis. So in summary, with sexual history and sexual health screening, focus on the history, be specific about sexual practices that patients might be engaged in. Always emphasize condom use. Make sure that you counsel about protecting, allowing patients to protect themselves for sexually transmitted diseases. Talk about HPV and chlamydia in females, well, boys as well, because the boys are the carriers of the chlamydia and often the HPV as well, so that should be included in your discussion with boys. So for chlamydia, asymptomatic, it's recommended that you check a routine probe during all your regular pelvic exams. And although males may have leukocytes in their urine as a result of chlamydia infection, that hasn't become a recommendation yet. So this is a wrap-up case, and since I'm about 10 minutes behind and I want to be sure you get a break before your next speaker, I'm going to let you use this as a review for yourself. But basically what I did is I put together a case that combines many of the topics that we've been talking about. And at the end of the case, there's a question for you. But basically, just so you know in advance, the answer to the question is to go ahead and facilitate conversation between the adolescent and her parents. That's always the best approach. And you can use this case as a review for yourself. So thanks again for your attention.